Hello, everyone. Welcome to my presentation on the future of clinician-patient relationship with conversational artificial intelligence. My name is Gary. I'm a medical doctor by training. I have two masters, one in public health and one in business administration. Currently, I'm a consultant with the Health Services Outcome Research in National Healthcare Group in Singapore. As part of my work, I also work as a clinical advisor for Health Empowered by AI Launchpad, which is supposed to scale AI solutions in the whole organization, enterprise-wide. You can connect with me through my LinkedIn profile as listed there. Okay, let's start. So imagine this picture. This is a typical busy emergency department. The question is, can we improve the patient's experience using conversational AI? Or are the patients doomed to always require patience? No pun intended. What is conversational AI? Basically, it means technology like chatbots, virtual agents that's able to facilitate human-like interaction through speech or text. Some of the core technology uses requires data utilization because it uses large volume of data to train a model. Machine learning, which is a continuous process of both training as well as improving the AI system, as well as natural language processing. To put in simple terms, how do you let the computer understand human language, enable understanding and translation of speech and text across languages, and of course, there needs to be a feedback loop so that the NLP and machine learning can be integrated into a continuous feedback loop to refine AI algorithm over time. And this is from IBM. Okay, let's compare. What is conversational AI versus generational AI? The two use cases are totally different. What most of you are familiar with is probably generational AI, which is ChatGPT, for example. The purpose of generational AI is to focus on content creation and generate novel and creative output. On the other hand, conversational AI focuses on enabling human-like interaction and provide useful response and conversation. Input and output. So this is some of the things that is the difference. One uses input in terms of languages and produces output that is also languages. But for generative AI, they can take structured or unstructured data and generate new content based on learned patterns. Common use cases for generative AI is in content creation, art and design. For example, some may be familiar with Midjourney. For conversational AI, is more of virtual assistant, computer customer service, as well as language translation software. But the data set chain are quite similar. You need large data set, but their conversational AI focuses mainly on text, user queries and responses, whereas generative AI focuses on a variety of data, for example, text, images, audio, so that patterns and can generate content. So our key takeaway is that conversational AI specializes in dialogue interaction, and sometimes they leverage generative AI to produce dynamic responses. On the other hand, generative AI is a much broader range of application focused on the creation of original content. So it comes back to my first question, is ChatGPT conversational AI or generative AI? At the end of this talk, I hope you can have your own opinion on whether it is one or two or actually both. So coming back to healthcare, since I'm a medical doctor by training, I'm not an AI expert, but my focus is on how do you apply AI in healthcare? What are some of the regulations you could look into? How do you use it in a responsible and ethical way? So in Health Science Authority in Singapore is the equivalent of FDA, Food and Drug Administration in US. What they say that is as long as AI is used for treatment, patient monitoring, diagnosis or screening, this is considered as a medical device. And we regulate it as a medical device, which means that the bar to clear is higher. However, if there's impact to patient safety, for example, in wellness, healthcare administration, it's not really considered as a medical device. And of course, it's indirect, for example, in training and research, again, no. Unfortunately, the most impactful area is often the most regulated one. These are the treatment, patient monitoring, and diagnosis screening. Come to the first case study. This is MyLine.xg. This is actually a collaboration between the Ministry of Health Transformation together with the other ministries and Ministry of Mental Health, which is one of the largest mental health hospitals in Singapore that focuses on mental health and psychiatry. So what this does is it provides mental health support. So note that this is mental health support. It's not meant to diagnose, it's not meant to treat, but it's meant to screen. And if there's anything that we detect, for example, if the patient is suicidal or homicidal, an alert may be sent so that the patient can seek help and care. For example, this is WISA. So this is actually a paid subscription, which the ministry actually paid for. It's an AI penguin they can chat with and talk to about anything. Interestingly, some people may find easier to talk to a chatbot rather than a human because majority of time humans do judge, whereas chatbot can be quite neutral or even encouraging. It helps to navigate the emotion and reframe any negative thoughts, and it's just here to listen. Imagine at 3 a.m. trying to call somebody to listen to you. You may not have such a good luck unless the person doesn't sleep. But for WISA, they can actually listen to you 24/7. So MySG uses clinically validated self-assessment tool. This is the patient health questionnaire 9, as well as the general anxiety disorders questionnaire 7. This helps to understand the anxiety or depression before offering a recommendation on next step. For example, it could be as simple as calling a helpline or doing a mindfulness breathing exercise. The individuals using this has a national paid subscription of WISA, which is free. And this is also why, for a lot of startups who try to offer this in Singapore, it's so difficult to compete because there's already an existing free version. To supplement a growing need for professional counseling and therapy, it acts as a 24/7 accessible pocket therapist that removes any mental barrier towards health seeking for emotional wellness. It understands user conversation and can recommend specific, interesting self-care exercises, for example, CBT, cognitive behavioral therapy. It can also give you exercises to target on the user trouble points. The key thing is that the purpose is to actually help the user. And of course, there needs to be some sort of a disclaimer that by using the website, you agree to its terms and data protection policy, and hopefully do not key in confidential medical data. And the government of Singapore will not be liable for any harm resulting from its use. And the recommendation provided for this website actually does not constitute a medical device. As mentioned, if it's a medical device, medical advice, it will be regulated as a medical device. Next, this is something that I'm very into because it's patient education. Because number one, as I mentioned previously, this is an area that is not really regulated by the regulators because it's not really considered as a medical device. This is the current patient education material. There's so many you can look for. These are the ones in Singapore. One is from Tan Tock Seng Hospital, which is the one I work in, and the other one from Khoo Teck Puat Hospital, which is another hospital. So you can see that it's a lot of colorful pictures, but the key thing is every of this is that number one is labor intensive to make, and even more labor intensive to maintain. So there are lots of information out there. In US, you can see, for example, Mayo Clinic, they do have a lot of patient education material and so on. So you can see that this is the current way. It used to be paper form, okay? And now they actually have it online, but you still need to click on it and something need to print it. So, future. What is the future? Can we use conversational AI for patient education? What is the reason for doing so is number one, it's accessible and scalable. And of course, if there's anything that needs to be updated, the AI can actually update it instantaneously. Also be merchandised and culturally relevant. A lot of materials are actually targeted at a certain health literacy level. What if you are higher than that? Or what if you're even lower than that? So you may not even understand some of the terms used. Or for some, it can be too simplified. It enhances engagement because you not only have information, you can actually chat with the information, you can ask questions which the materials can't answer. It helps to simplify complex information. And of course, the most important thing is to empower patients. Because if patients know more of their medical condition, they're more likely to ask relevant and insightful questions about their condition, rather than the very generic questions like what is the cause of type 2 diabetes, things like that, which can be easily found. This is a project I'm working on. It's almost completed. It's to enhance lung function tests AI-driven solution using a biodesign approach. So you may know that biodesign actually originated from Stanford Biodesign. This helps to improve the patient experience, efficiency, outcome through innovation. So lung function tests are critical for diagnosing asthma and chronic obstructive pulmonary disease. In one of the hospitals in Singapore, there's an estimated 10% no-show rate, which means that patients don't turn up for their appointment. Even for myself, I recently did a lung function test last year. I need to repeat the test several times, and some of the tests you can't just repeat it straight away. They need a period of washout. So the key question is, how can we make lung function tests easier and more accessible to everyone so that people can use it, they will reduce anxiety, and they'll also be taught how to prepare for the test. So the bio-design approach, there are three components. First is identify, invent, and implement. Traditionally, this has been used mainly in medical device, but the concepts and principles can be used. First is to understand the patient. Ideally, we should observe the patient as they go through the patient journey. But because we have limited time, what we did was we did the next best thing. We actually interviewed the physician, the provider, working in the lab, so to find what are the key pain points and some of the things that they actually experience. Luckily or unluckily, I'm a patient myself, so I was also able to give some feedback on how the process could have been improved. The first thing is, patient may miss appointment if not reminded. So you don't really need to have AI to do this. You just need to have an automated system to actually remind patient to come for the appointment. But a lot of times, appointment may be a couple of months, couple of weeks later. So the patient may not remember what the test is for. So you not just need to remind them for the appointment, you need to explain to them what is the appointment, what are the tests for, how to prepare for the test. Because, for example, if you go for spirometry and you take your medication, it may actually interfere with the results. And you go for a certain test, for example, you take coffee, this will also again, it affects the heart rate, affects the accuracy of the test. And lastly, there's also anxiety performance. If I only know what I need to do at the spot, I may not be able to understand. For example, one of the things you need to do is to breathe out slowly. And this is something that I wasn't prepared for. As a matter of time, I actually breathe out too fast and to repeat the test. So anxiety performance can also be improved if you know what you're anticipating, so you can know what to do. For example, this is for a home sleep test. The question is, can I drink coffee? So this chatbot will actually go through the information you're given and says that we recommend to avoid consuming coffee. Why? This may affect your sleep test. Because it can explain why also. Because it's not important to just say, you can't do this. You need to explain why. Caffeine can affect sleep patterns and accuracy of tests. And therefore, it's advisable not to have caffeine. Okay, this is quite simple, but there are certain tests that are actually quite complicated. For example, colonoscopy. Again, unfortunately, I went for colonoscopy. So there are many different regimes, different ways to do a prep. If you don't do a proper prep, you may have a suboptimal colonoscopy and you need to repeat it again. So after doing this, I came across this framework to say how do you evaluate medical output from a large language model. So there are 5 things we look at. The short form is QUEST acronym. Q, we look at the quality of information. If you look at this paper, it goes more in depth into the different components of the 5 areas. U, understanding and reasoning. E, expression style and persona, whether is it a professional or whether is it a more layperson. Safety and harm, that's S, very important, because you cannot provide inaccurate information and you need to fact check. So a lot of LM currently nowadays, they do annotation, they do citation to ensure that there's no or minimize hallucination, or actually I call it confabulation. The correct term, I think, is confabulation, where because of limited information or gaps, they come up with a story to have a complete picture. And finally, you need to have trust and confidence. If you have too many errors, too many hallucination, confabulation, this will affect the trust in using the large language model. Case study 3. Okay, this was by my colleague. What they did was they actually looked at whether can use AI to do a pre-triage history taking. In the emergency department, a lot of times you have long waiting time. And while waiting for the doctor, you're very anxious and you're very angry. So can we take a quick history using a triage so that we can decide whether is it urgent or it can wait because there are other people that's much more critical. So the large language model can actually take a targeted history from patient, so it can be able to see whether it need to actually be up triage or alert a nurse to actually alert doctor to see earlier. This support is supported by a dynamically formulated approach and internal chain of reasoning. And they found that the prototype has comparable concordance according to the ED physician. So it's almost as good as a emergent physician. As you know, ED physician time in the ED is actually quite valuable. If you can free up their time to do triaging and if it's accurate enough, these patients can actually be seen earlier and the ED doctors can actually focus on taking care of the urgent cases first. Of course, coming back, there are certain challenges and ethical consideration. For example, in Singapore, we have this thing called PDPA. It stands for Personal Data Protection Act. So what it does is you need to make sure that there's data security and there's no leakage of information. Obviously, before you can use any, we need to get an informed consent, either is it implicit or explicit for use. So when I see a doctor, I may allow my information to be used to treat me, but I may or may not allow my information to be used to train a model that will diagnose other people or even me in future. So it's very important to get informed consent from patients on how the data is going to be used. This is to be transparent. There may also be biases because if you just use a data set from overseas, for example, US, they'll group all Asians as group all the races in Singapore as Asian. In Singapore, we have Chinese, Malay, Indian, and others. All of them have different disease pattern as well as risk factor. But if you just group them all as Asian, this may actually lose the discriminative ability for AI to do that. Therefore, the AI needs to be fine-tuned using our own Singapore data. And of course, some of the biases has been long-standing. So you can look at the literature. For example, historically, the blacks may have poor outcomes in some of the assessing the care, and the AI may reflect that. And if you're asking who should we save, it may actually make the inequality worse. Next is regulatory challenges. Of course, we need to align with our Ministry of Health guidelines while balancing both innovation with compliance. It's very easy to be compliant. You just need to not do anything. Then you'll be definitely compliant. On the other hand, it's also very easy to be very innovative and then you run foul of the rules. So the sweet spot is to do this in a certain way with guardrails so that you can actually hasten innovation without fear that you're violating the laws. So our mitigation strategy is to have robust testing, make sure the AI system is both reliable and fair. Human oversight. So they call this a human in the loop. So at the end of the day, the humans, the doctors, the nurses are responsible for the intervention taken that is recommended by AI. You cannot blindly follow the AI. You have to let the AI be a way to recommend, to check, and then you still need to maintain clinician involvement. For example, if you think that the patient is safe to be seen later, the AI may suggest something different. Then you just have a quick look and see whether you miss anything. Because sometimes if a doctor is tired, if the nurse is tired, and fatigue sets in, and your mind is so full of other patients, you may miss certain things. So AI can take as a second check to make sure it's like spelling check. It can help make sure that there's no error. And of course, you disagree with the AI recommendation, you can overlook it, but you have made a conscious effort to actually consider it and decided that it's not, you don't agree with the recommendation. Finally, you need to tailor AI to local communication style and of course healthcare expectation, because ultimately, does the patient wants to use AI? Does the patient wants to talk to AI? These are some of the things we do handle. From what I know, for the elderly patients, they may more be comfortable with speaking to an individual. In that case, should we train AI to be more human-like? But we need to inform them that it's still really talking to AI, even though it sounds like humans. So some of the key takeaways in this is that definition and core technology for this human-like interaction via chatbot, virtual agents using data visualization, machine learning, natural language processing, of course, a feedback loop. All these are very important so that we can actually drive conversational AI. I also share some of the case study how AI can be used in mental health services. In this case, it's more of mental wellness, but nothing is stopping you from actually moving into diagnosis or management of patients, provided that it obeys the rule of the land. Patient education, this is something that is more exciting because most of the time, this area is less regulated. because you're actually informing patients of certain things. There are a lot of things on the internet. Some of them are accurate. Some of them may be less accurate because it's dated. So a lot of times, clinical practice guidelines actually are withdrawn every 5 years. But you do see the patient activation material existing, and it takes a lot of time and effort for somebody to update the information. You can also use it to do a pre-triage history taking. This helps to actually focus the ED physician, the emergency doctor physician time to take care of patients of high acuity. And in the worst case scenario is that the patients will be seen later. But at the same time, currently now, even if you use the first come, first serve, you still have this problem. And even asking a doctor to do a triage, the patient can still deteriorate. So there's no win-win situation. So you just have to judge whether the use of AI balances, the benefit of using AI benefit the risk, overrides the risk. Some of the challenges and mitigations is the Patient Personal Data Protection Act. Make sure you're complying with the and taking consent from patients. Using data set that's diverse to make sure that you can actually reduce the biases. Of course, for regulations, you need to make sure understand the regulation. The key thing is before you do anything, you need to know what you can or cannot do. If you're not sure, you can always ask the regulator, and then you can help to align some of the innovation regulation. At the end of the day, the regulators are there to protect the patient. And overall, if this innovation helps to reduce waiting time, improve patient outcomes, they're more than happy to test it in a safe manner. So a lot of times we need to do a clinical trial, we need to do a sandbox so that this can be done without affecting real-life patients. Mitigation strategy need to have testing, human oversight, human in the loop, and of course need to be cultural adapted so that the terms used are also appropriate. Because you cannot just buy a chatbot from overseas. For example, as simple as British English, American English, all these are big differences. Certain slang use are different, so the chatbot may actually interpret if you just use a one that is taken overseas. So even for Chinese, there's actually 3 different types of Mandarin. You have the simplified Chinese, which is used in China, and you also have the traditional Chinese used in maybe Hong Kong or Taiwan. And even in Singapore, certain terms you don't use. So it's the same language, but there are some nuances in where you use it. Not to mention the different dialects. Of course, I think Peter Tucker said this, and that's the best way to predict the future is to create it. Yeah. With that, I hope you have understand a bit about conversational AI, some of the potential of using it in different areas. Because of limited time, I only share 3 use cases that is currently used in Singapore. There is either a pilot or we have actually tested it in a small manner. And we hope that you get inspired to actually consider the use of conversational AI in your day-to-day work. Thank you so much. I hope you enjoy the rest of the conference. Thank you.